All right, so let's talk about altered mental status. Altered mental status, or AMS, is the abbreviation when you see altered mental status. There is a laundry list of things that can cause altered mental status. There's hypoglycemia, hyperglycemia, drug intoxication, alcohol intoxication, hypoxia. I mean, you just go along and along and along, and all of a sudden you have this decrease in mental status. Remember, the way that we judge mental status, the way that we put a definition on it, is alert to person, place, time, and event, right? So A&O times 4, let's say we see that you have a mental status where you can essentially make decisions for yourself. This doesn't mean that you can't have an altered mental status. You can be A&O 4 and still have an altered mental status. All right, so there's some judgment that goes in there. And like it says, it's a sudden, like hypoglycemia could be a sudden decrease in mental status. The stroke that we're going to try to get to is going to be a decrease in mental status. Just a level of responsiveness. All right. So, Randy's rule for altered mental status is that any altered mental status, you always check a D-stick. And a D-stick is dextrose. D stands for dextrose, or blood sugar. So we'll look at that later. We won't look at that today. We'll look at it as we go into diabetic emergencies. But now and forever, when you have an altered mental status, you check a D-stick, dextrose stick. We'll define those numbers later, but what that tells you is that whether your blood sugar is low. A large majority of altered mental status is due to a low blood sugar. So you always check that. What do you do if you present with a patient? Let's say EMS came into your ER. They say, blah, 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 here it is, altered mental status. Pick this lady up from the nursing home. And the nurses at the nursing home says she has dementia. Her normal mental status is altered. And she normally has an altered mental status. That's the norm for her. What do? Check the blood sugar level. Always check the blood sugar level to make sure that it is within range. That's very important. You don't understand how many people fail to do that. You know, just one in the emergency room, I forget who was in there with us. They brought a person with an altered mental status from across the street, from the specialty hospital. When they were asked about the D-stick, they didn't do one because they were across the street. And it looked bad for them. Her blood sugar ended up being within normal limits, but it still looked bad because they should have checked the blood sugar. It only takes 15 seconds to check a blood sugar. Some of the machines are quicker than that. That's a slow machine. Some of them will spit the number out very rapidly. So make sure that you always check a blood sugar level. Very important. So here's some other things. Seizures causes altered mental status. They go in what's called a post-ictal state. We'll talk about seizures later. Stroke, diabetes, poisonings. Kids, little 3 to 5 year olds are huge into exploring with their mouth. They pick something up, lick it, put it back, drink bleach. Breathing problems, hypoxia, cardiac events. You decrease cardiac output. You're going to have decrease in oxygen. Don't cause some cerebral hypoxia. That's going to cause an altered mental status, or could cause an altered mental status. We are already aware of the AVPU scale, alert, and this is to eye opening. So far, I haven't lost anybody. Everybody's eyes are open. So according to this scale, everybody is alert. We don't know to what yet, but we know that you're alert. Remember, if your eyes were not open, I'd come up and say, hey, are you okay? And if you responded to that verbal stimulus by opening your eyes, then you were alert to verbal stimulus, where the next one would be pain if you didn't respond to the verbal stimulus, then give a sternal rub, and that that painful stimulus, and then you be considered unresponsive if you didn't respond to the painful stimulus. Here, eventually we will get to where we're saying you're unresponsive with a gag reflex or unresponsive without a gag reflex. The gag reflex is the reflex, remember, to help us protect our airway. So if the patient was to vomit, being unresponsive, if they had a gag reflex, they would have a greater chance of not aspirating the vomitus. If they didn't have a gag reflex, then they stand a better chance of aspirating. And there's several ways that you can check a gag reflex. One way that you can check a gag reflex, that's somebody that's unconscious. One of my favorite ways is you tap on their eyelids. And if their eyelids flutter, then they typically will have a gag reflex. The other way is to stick something in their mouth. Alright? And if they gag on that you're sticking in their mouth, then they have a gag reflex. We haven't taught you these, and probably won't, because you guys coming back for the EMT class, we have to leave something to teach you. Called an OPA, or oral pharyngeal airway. This provides an airway where you don't have to do the head tilt chin lift. This goes in the mouth based on the back of the tongue, and it pulls the tongue forward. Okay? It's not a big thing to learn, it's just one of those. And inserting this in someone's mouth with the gag reflex, as soon as you got past where their gag reflex was stimulated, then they would, right? So this is what I mean by put an OPA in and see if they have a gag reflex. I might put, if I didn't subscribe to the eyelid flutter, then I might stick a laryngoscope in their mouth. I stick a laryngoscope in their mouth, and then they might start gagging on that. All right? So unresponsive without a gag reflex is considered an airway problem. Then we look at this, the GCS, Glasgow Coma Scale, and this is a scoring device to help us determine, give us a number. What does that number give us? So we don't come up with a number here. What does that give us? Right, so, yeah, you can... Severity. You can see how decreased their mental status is, and also as you start treating them, how the mental status is coming up. So it puts a number there, which tells you either you're doing worse or better, right? So eye-opening, right now, all you guys will get a 4. All your eyes are open, so you have a 4 there. And this goes with the ABPU scale, the eye-opening, okay, pretty much. The next thing you look at is a verbal response. If right now everybody talking normal, you're answering questions, right? So you would get a 5. If you were disoriented, so we started speaking to you, and all of a sudden you're not sure where you are or where you're going or what's taking place right now, then you get a 4. If your words were incomprehensible, is probably a better word there. When you speak, you're just sort of blubbering. You know, you're not making any sense at all. The words you're saying are coming out, but they're not making any sense. Then if you're not speaking at all, you might just be moaning. Then you get a 2. And none, get a 1. Okay? Then you move over to the motor response. Everybody can move their arms and legs. They have a normal motor response. Then you go ahead and get the 6. If you're laying there, decreased LOC, but you respond to the sternal rub. So someone starts doing a sternal rub and you reach up and push their hand away. You respond to pain by pushing away. Withdrawing from pain would be if you were going to start an IV or something. You stuck them with a needle and they sort of withdrew their hand from that. All right, that's a 4. See how you start going down? This one, number 3, this decorticate posturing. Decorticate posturing is when you draw up. So the patient's laying there and their hands are drawing up towards them. So they're laying there sort of like this with their hands. The way I remember that is, it may not be as easy for you, but to carry a cord of wood, a cord is an amount of wood, so you carry that, and the way that you carry it is with your hands up underneath, like this, and so your hands turn inward. Does that make sense? That's how, that many years ago I remember decorticate posturing. Decerebate posturing is when the hands are pushed away, like you're pushing something away. So you're laying there and your hands are out like this. Now, both of those are telling you that there's a brainstem problem. Decorticate and decerebate posturing telling you that something is wrong with the brainstem. You might be herniating. Like in trauma, you could suspect a herniation in this type of posturing. That's decorticate and decerebate posturing equals bad. Those are bad things. Then nothing there is not so bad, okay? You just have no motor response. Abraham Lincoln has a 3, right?
After you got shot?
Abraham Lincoln has a 3. If you were to dig Abe up and his bones were sitting there, he would have a Glasgow Coma of 3, correct? No eye opening, no eyes. Okay?
Oh.
Not talking to you, and he's not moving. So see, they have a Glasgow of 3. A Glasgow of 3 is very poor. There's a term that calls less than 8 intubate for ALS, paramedics, doctors. A Glasgow of less than 8, they consider your airway unprotected. So they're going to go ahead and place an airway in there more than likely to protect your airway. What's the maximum score? 15, right. When we speak to trauma, when we get into trauma, there's what's called an RTS, revised trauma score, that adds in blood pressure and pulse rate, I believe. But we'll look at that much later. So you can see, let's say you started out with a Glasgow of 13, and all of a sudden you give them oxygen, and now they're coming up, right? Then you can see they started at 13, you gave them oxygen, and they got better. So now they're at 15. So it gives you a range of how to go with. Everybody good with the Glasgow Coma scale? All right. Let's talk about strokes. We've talked about strokes just a little bit with CPR. A stroke, remember, is considered really sort of a slang term they use, a brain attack, right? Just like we just spoke about a heart attack, we have that blockage in there. You can have a blockage in a cerebral vessel, a cerebral artery, that's going to cause a stroke. And from that stroke, you're going to get a dead spot on the brain. Remember the picture? I should have added the picture in here. Remember the picture from the beginning of school that had the black spot on it? Okay? That person had a stroke, and that's what it looks like on the brain. So if they did an autopsy, they would look at that and say, yeah, they had a stroke. It's right here. It's a pretty large stroke. So it's a blockage or a decreased flow to the brain. You also have what's called a hemorrhagic stroke. Hemorrhagic or hemorrhage means what? Bleeding. So the one with the clot is called an ischemic stroke, and the bleeding stroke is a hemorrhagic stroke. So you have ischemic and hemorrhagic stroke. You have those two. The signs and symptoms are the same. So that's what's good. You don't really have to figure out anything different on the signs and symptoms. So headache, paralysis, usually hemiparalysis, like the motor, hemiparalysis, which means what?
Half of the body?
Well, half, or one side. So people who are experiencing stroke-type symptoms are having this paralysis on one side of the body. Now, it's just FYI information, but if they're having, let's say, right-sided weakness, the stroke is typically on the left side. It's on the opposite side of the body. Also, a side note is that you never do any type of intervention unless just absolutely necessary to the affected side. So if they're having weakness or paralysis on the right side, you do everything on the left side. So vital signs, needle sticks, everything on the left side. Never do anything on the affected side. Confusion, where's the confusion come from? Where's that come from?
Brain messing up.
Well, yeah.
Lack of oxygen.
Well, lack of oxygen. So syncopal, what's syncopal mean? Fainting, right. Then hypertension, high blood pressure is really of a hallmark sign. Headache, dizziness, high blood pressure, confusion, these are all hallmark signs. So when you look at it, here you have the, can y'all see that well enough where you see the clot on this one side? And that's just like I would present the same way as a heart attack. I mean, not with chest pain, but it would do the same as to the heart, but to the brain here with this clot. It would decrease or stop blood flow to that area of the brain, and then that area of the brain would infarct or die. So you would get a stroke. Now, down here at the bottom, the full name for the stroke is cerebrovascular accidents, or CVA. So when you hear the term CVA, they're talking about a stroke. Most people just go ahead and say stroke. So now the other one we talk about is a ruptured vessel. And that ruptured vessel is a hemorrhagic stroke, meaning that they're bleeding inside of the brain. Now, there's several different types of head bleeds. We'll speak more of the head bleeds when we get into trauma. But let me write down, let me see if I can go to the board here. There we go. The different layers, or the meningenes, really difficult word for me to say. Meningenes, right? Huh? Yeah, you know what I'm saying. The different layers of the brain, the outermost layer after we get past the skull is called the dura mater. Now you have the skull here, and you can see it more prominently on me because I'm one of the fortunate ones without hair. You know you can't trust people with hair, right?
I've been people without hair.
But when you look at the scalp and you feel the scalp, I mean you can do this like on your frontal lobe, your forehead. That bone feels like it's right there, correct? I mean it feels close. But you have to look at that. So when you look at this layer, because you have skin, then you have some vessels, and then you have subcutaneous tissue or fat, right? And it's all just sort of stretched really tight. I got some really cool pictures of open head injuries. When this opens up, it's like a sponge. You know when you buy a sponge, it's really thin, right? And then you throw it in water and it expands out. That's the same way that the scalp does. When the the dermis is cut and this expands out a lot of tissue. There's a lot of space in between the skin and the skull that absorbs energy. Like if we were to get hit in the head, it would absorb that energy along with the bone. Not a great deal, but there's quite a bit of tissue there that sort of expands out. So you have the skull, then right under the skull, with the cranium, you have what's called the dura mater. Those Latins kill me, but dura means tough, mater mother, so tough mother is what dura mater means. It's pretty cool. I've held some before. You can't tear it. The guy handed us the dura and said, "Here, go ahead and try to tear this." Man, we're sitting there trying to rip it, and you just won't rip. It'd make a really good wallet if it wasn't so weird, you know, to have dura mater as a wallet. But it just won't tear. Very tough. So you have the dura mater, the other, right under the dura mater, you have the arachnoid.
Is it under the skin or the skull?
Huh?
The dura mater, is it right under the skin or under the skull?
Under the skull. Yeah, the dura mater is right under the skull. Under the dura mater, you have the arachnoid space, and then you have the arachnoid vessels in there. Where do you think they got the term arachnoid from? Spiders. But because when they popped this skull off and they looked at that the first time, they're saying, "Man, that looks like a bunch of spider webs." Remember, these guys, when they were doing these first sort of things and naming all this, they named it for what it really sort of looked like, you know. So the arachnoid space, in the arachnoid space, in the arachnoid vessels, is where the cerebral spinal fluid is. The cerebral spinal fluid is, I mean, it has many functions. It transports, you know, nutrients and waste, and it adds. Acts like a shock absorber to the skull, to the brain. I mean, it has many functions, but in the arachnoid, you have the arachnoid layer there, where the cerebral spinal fluid is. CSF, cerebral spinal fluid. And then under that layer, you have the pia mater. And I forget, but I think that stands for tender mother or something. Anyway, the pia mater adheres to the brain. It lays directly on top of the brain. So you have these different levels, these different sections of the brain, different layers. Now, if we go here and we write in the word subdural. What do you think that means? Under, dural? The dura. So subdural is the space that's under the dura mater. Okay? This is where you get a type of bleed that we're going to talk about, just briefly. All right? You get what's called a subdural bleed. A bleed that's taking place under the dura mater. Now, there's things about a subdural bleed that are that you would notice differently now than another type of bleed, but it would be different than a ischemic stroke. So if they were having a hemorrhagic stroke, more than likely it's going to develop a subdural bleed. Now, a subdural bleed is a venous bleed. That's very important. Venous bleed versus an arterial bleed. What does that tell you?
Is it bleeding from a vein?
Yeah, from a vein, and then
It's not erupting blood.
right, and it's not under a great deal of pressure, so that vein is going to bleed slower, right? So a subdural bleed is going to take longer for the signs and symptoms to manifest. A subdural bleed you probably won't see from 12 to 48 hours. Then you start seeing all the signs and symptoms of a head bleed, which are pretty much the same signs and symptoms of a stroke. There's some differences in there that we'll speak of throughout, okay? But a lot of them are the same signs and symptoms of a stroke. So a subdural bleed, what you're going to have is a slow in onset, it's a venous bleed, 12 to 48 hours, right? And then you're going to start getting confusion, headache, dizziness, paralysis, nausea, and vomiting. Nausea, vomiting is very key for a head injury. You know, if you're in a traumatic event and you hit your head and you're confused and you know you have an altered mental status and then all of a sudden you start vomiting, that's a big key sign. That's a problem. So all that takes place with a subdural bleed. The other bleed that's under the dura, let me just write it off to the side. It's an epidural bleed. Whoop, I didn't want to do that. Epidural. Can you get the L in there? No. I keep jacking that up. Okay. Epidural bleed. And the difference between the subdural and epidural bleed is the epidural bleed is an arterial bleed. It's an artery, which means that it's going to, this onset of signs and symptoms are going to be very quick. Versus over 12 to 24 hours. And it's going to bleed faster. So we'll leave that alone for right now. We'll come back when we talk about trauma and head injuries. But under the dura, you have the subdural and epidural bleed. The subdural bleed is a slower in onset. It's a venous bleed. Signs and symptoms, 12 to 24 hours, or 12 to 48 hours. Epidural bleed, sudden onset. Arterial bleed, very fast. Signs and symptoms, very fast. So as everybody good there? No questions? Questions? Okay. So as we start working our way down through the layers, now you have this arachnoid layer. And underneath the arachnoid would mean what? Subarachnoid. Now you can have a subarachnoid bleed, but it's not really associated with the stroke. It's not like a hemorrhagic stroke. You're going to get that up in the sub and epidural bleed. A subarachnoid bleed is very common in the elderly, way more older than I am. Okay, and very common with alcoholics or alcohol abusers. Okay, which are usually alcoholics. Okay. If you look at the subarachnoid level, let's say this heart is the brain, and my fingers are the arachnoid vessels, okay? They adhere to the brain. And once they get dehydrated or damaged, they sort of stretch out. Then they get rehydrated and they sort of go back to normal. They get dehydrated and they stretch out and they go back to normal, right? And over a period of time, what's going to happen to those vessels?
They lose their elasticity.
Oh, good. They lose their elasticity, they stretch, and then they weak, just like a rubber band. If you keep stretching a rubber band back and forth, eventually it's going to weaken. Okay? Hopefully you guys don't know this, but when people have a hangover, okay, that's what takes place. Alcohol is dehydrating. It dehydrates you. So when it dehydrates, those vessels constrict or they stretch up. That's what causes the headache, the dehydration. And it stretches up on that brain and it signals that brain, oh, my head hurts. The head hurts because you're dehydrated. And the arachnoid level in there, those arachnoid vessels are stretching on the brain, essentially. Right? Now, over a period of time, these vessels are going to rupture and it's going to have a subarachnoid bleed. Elderly people are very common with this as well. The brain shrinks as we get older. Those vessels stretch or they just become old. Right? So those are the two common things. So when I talking about someone that I suspect that has a subarachnoid bleed. Here's what they usually say. It's one of those weird things. They present to you and they say, I've got the worst headache of my life. And you can just see the pain sort of dripping off of them. They say, my head is killing me. You rule out migraines, okay? And you primarily rule that out by asking them if they have migraines or if the pain is sensitive to light. So they said, no, it's just the worst headache I've ever had in my life. Right? And then you start in on your sample and you're asking them questions. You ask them, are you nauseated? I said, oh yeah, very nauseated. So my thought process of a subarachnoid bleed is going up. And then they say, yeah, I've been vomiting too. Slam dunk. You have a subarachnoid bleed. I mean, until proven otherwise. Those are just like a chest pain. Someone sitting on my chest, nausea, vomiting, shortness of breath. All very classic signs of someone having a heart attack, right? Someone telling you that they've got the worst headache in my life. They're nauseated, they're vomiting, they probably have a subarachnoid bleed, at least until you rule it out. How do you rule that out?
How would you rule out
The bleed.
If they have the wrong, if they say they are not even have them.
Well, yeah, I mean, how would you rule out just any kind of head bleed? You think of your kitty. CAT scan, yeah. This patient would go to the hospital, they do their assessment, they take them to the CAT scan, they spin their head, and they look and see if there was bleeding inside their head. All right. Now there's a lot to head bleeds, even some subdural bleeds. They will just look at them, a small subdural bleed. They will just look at it and maybe it's going to stop. They say, let's see if this stops, okay? Because where in the head is there space for blood?
There's space in between the bones
Huh?
and
No, the answer is there's not.
Oh, okay.
There's not room for blood. So as a person starts bleeding in their head,
it starts drumming.
well, it starts pushing the brain or shifting the brain. And over a period of time, it's going to shift it and it's going to push the brainstem down through the hole in the bottom of the skull, called the foramen magnum, and that's called brainstem herniation. And we'll get to more of that when we get into trauma. But it pushes this brainstem down that hole. The hole is too small for the brainstem, so it squeezes it together and pushes it down there. And that's where you start having a lot of the pupillary response. One pupil blows, it gets really dilated, and another one shrinks. So you have unequal pupils. That's a sign of brainstem herniation. It all comes from this bleeding. Right? And they hope it's going to bleed. It's going to stop bleeding. Okay? The pia mater just adheres to the brain. It doesn't have a level to it. So when you look at the three types of head bleeds, you have a subdural, epidural, and subarachnoid bleed. Subarachnoid bleed is not associated with the stroke. We just threw that in for extra for you, okay? So when you look at that, but the signs and symptoms of these head bleeds are the same whether it's trauma or whether it's stroke. If a ruptured vessel is a ruptured vessel, right, it doesn't necessarily care how it ruptured. You could get hit in the head with a baseball bat and rupture a vessel, or you could have hypertension and stroke and rupture a vessel. It's still bleeding in the brain. It's the same, right? Okay. Now, when you look at this, you have this thing called ICP. You don't want a CP, or I don't want a CP, but ICP stands for intra meaning what? Inside, intracranial pressure. every one of us has a pressure inside the skull. It's called intracranial pressure. Your pressure is higher than mine right now because you're sitting with your legs bent. Your intracranial pressure is the lowest when you're supine. So the blood, the clot, all that, the ischemic or the hemorrhagic stroke increases intracranial pressure. That's one of the problems. That's where you get all the squeezing and pushing, right? Pressure goes up. I'm not sure of what the normal is. I think it's, somebody can Google that right quick for me. It'd be cool. Normal intracranial pressure. I want to say it's around 10. What they do, if they're concerned about your intracranial pressure, they take you at a neurological hospital like Zell or Parkland or Baylor, and they will drill a hole in your skull, and they'll put what's called a bolt in there. And in this bolt, that wires come out, and they can measure intracranial pressure. They can evacuate blood if that's what they want to do from this bolt. So they're in a stroke, especially a hemorrhagic stroke, they're very concerned about intracranial pressure. Norms?
It says 7 to 15 millimeters.
7 to 15? Well, I was in the millimeters?
And then
Mercury.
Millimeters of mercury. Okay.
Mortality rate? No.
So the norm is 7 to 15. So up above, does it say in there what's not compatible with life?
The mortality rate is 20% of elevated ICP.
Yeah. So it's up there with the ICP. When they get ICP. I've got a student, former student that's working on the stroke floor at Baylor now. And so they have a complete floor of strokes or head injuries. The nurse here is a former neuro nurse. So she's very familiar with the ICP and the things. She used to work at Zell next to Parkland. It's one of the neurological hospitals. We'll talk about that much later when we get into head injuries. We'll talk more about ICP and these different bleeds, okay? But for right now, since this is just an overview, remember 2 types of strokes, hemorrhagic, ischemic. Under hemorrhagic, you can put little sub-bullets, subdural, epidural. All right? And then beside subdural, you want to put slow in onset, 12 to 48 hours, headache, nausea, vomiting, and these other signs that potentially could be having a stroke, the other signs of a stroke, paralysis. All right? Epidural, sudden onset, arterial bleed versus the venous bleed on the subdural, right? But the signs and symptoms are the same. Just a quicker onset. So let's look at your treatment right quick for CVA or a stroke. FAST, remember the acronym FAST? Facial droop, for the F, facial droop,
Yeah.
right? Arm drift, speech, then time. So you do that part assessment, you do that FAST assessment, you look to see if the patient had facial drooping, you'd have them hold their arms out. This is part of the Cincinnati Stroke Scale, and they get an arm drift. One arm would drift down, then they slur their speech, like you'd ask them to check they going up a hill, they couldn't say they slur their speech out, and then you'd want to get, what time did all this start? You'd still complete your sample, OPQRST, get good set of baseline vitals, and then you'd want to position the patient if you had to lay them flat, not on the affected side. You'd want to roll them in a recovery position opposite of the affected side. So if I was the right side, if I had hemiparalysis in my right side, I'd roll them to my left. All right? The other thing that you'd want to check is grip strength. Remember that head to toe exam, we said equal grips. So if you had hemiparalysis, you'd have weak grips on one side, right? So check grip strength, plantar flexion the same way with your feet. Now, your treatment here, high concentration of oxygen, same as a heart attack. They need supplemental oxygen, right? This patient needs to go to a stroke center. They need to go to a center that specializes in stroke. And most of them do. Most of the bigger hospitals are considered stroke centers, like the Baylor's, the Parklands, Presbyterians, all those are considered stroke centers. Because this patient needs to go, if they have this sudden onset, and we mean sudden onset here when we talk about stroke, it's in 3 hours. Right? If they're in 3 hours of signs and symptoms of a stroke, this person needs to go to a stroke center. They need to get into a CAT scan as soon as possible. Then a stroke center has the neurologist there. You know, we talk about the cath lab, right, for the heart. They will do the same for the brain. They will run a catheter up in through there and balloon that vessel out in the brain to provide oxygen flow. Without taking, the patient goes to a non-stroke center, then it's going to take more time because they don't have the neurological means to run the catheter in there. It's pretty cool. Oh, thanks. I guess you just wanted me to stop, right? Is that it? Sure. Oh, it's 11. Yeah. Hey. No, since you, it's 11. Stop. Shut up. All right. One other thing, and I will stop. Since I was forced to.
Did you want me to remind you or not?
TIA stands for transient ischemic attack. Or you might put mini stroke. A TIA will present with the same signs and symptoms as a stroke, but they will resolve over a period of about 24 hours, within 24 hours. The Texans, everybody heard about the head coach of the Texans?
Yeah.
He had a TIA. They diagnosed him with a mini stroke.
Like actually, right before happened.
Yeah, so
He didn't pass away, he passed out.
He passed away.
Pretty sad. They had
So-
to put him in the interim coach.
all the signs or symptoms the same as a stroke. They look like a stroke. They look like they're having a stroke. But I've seen them as fast as you put a non-rebreather on them. The signs and symptoms went away. Right? The most expensive one I've ever seen is it was in Wills Point, I believe. They thought this person was having a stroke. They called us, picked them up in a helicopter.
Oh, God.
They thought they were having a stroke. Makes sense, all right? The patient needs to go somewhere higher level. They were a long way by ground. It all made sense, but we put that non-rebreather on her, and before we got to the hospital, which was about a 20-minute flight, all of her signs and symptoms had went away. She had a TIA instead of a CVA, okay? And the trip cost her about $20,000.
Wow. Don't ever pick me up.
So, but they erred on the side of caution, which is good. You think about the side of caution for the patient.
You didn't think of anything personal.
Jeez, bring him back.
Connor said he didn't think about her.
$1,000.
Bank account. You didn't think about her.
Questions? Everybody, any questions?